Now let's discuss amino glycosides. So in the name itself, you have amino and glycosides. They are two or more amino sugars attached by glycosidic linkage to a hexose ring. Okay, so they include streptomycin. So amino glycosides, mycin. So mycin, gentamicin, streptomycin, amikacin, kanamycin, etc. Amikacin is amicable. It has the broadest spectrum of activity. Strepto, T for tuberculosis. Genta, it is gentle, so it's not used in tuberculosis but in other drugs. Okay, gentle, so air, right? So effective in Pseudomonas aeruginosa, etc. So, two or more amino sugars attached by glycosidic linkage to the hexose ring. They're highly polar compounds, so poorly absorbed. So, paromomycin, example, right? So, they're given parenterally. So, they're mainly distributed in extracellular fluid, not metabolized and excreted as it is in the urine. So, they have bactericidal action against gram-negative aerobes. So, no, right? So, negative aerobes and are more active at alkaline pH. Why aerobes only? Because to enter the bacterial cell, oxygen is required. So, they are effective against only aerobes, not against anaerobes. So, anaerobes are resistant to aminoglycosides. They cause ototoxicity and nephrotoxicity. So, amino, nephrotoxicity, neuromuscular block, and O for ototoxicity. Okay, so that is what is shown here. So basically, mechanism of action and aminoglycosides are bactericidal agents. They inhibit protein synthesis. So they first enter the bacterial cell, oxygen is required, then they bind to 30th subunit. What they do is, first they inhibit the initiation of protein synthesis, and when elongation is going on, they incorporate defective proteins or wrong amino acids into the peptide chains, and they prematurely terminate it. So initiation stopped, elongation, wrong amino acid incorporated, termination, it is premature. Okay, so all this results in formation of defective proteins, which causes incorporation of defective proteins into the bacterial cell membrane, altered permeability and disruption of the cell membrane, bactericidal effect. So mechanisms of bacterial resistance, so decreased entry of the drug into the bacterium because of decreased O2 or whatever, and decreased affinity. So aminoglycosides, see, they're like sugars, right? So more the sugar, more the sweetness, so more the effect. So more the sugar concentration or drug concentration, more the effect. So more concentration killing, dependent killing effect. Okay, next, dosing. Once daily is as effective as multiple dose regimen, so that is why once daily is preferred, and it is safer than multiple dose regimen because the plasma concentration remains below threshold levels. Okay, multiple doses, 2 or 3 equally divided doses per day. Next, adverse effects, ototoxicity. So because these sugars get concentrated in the perilymph and endolymph, they affect the vestibular function. So they disturb the hair cells, they cause headache, dizziness, nausea, vomiting, vertigo mainly, nystagmus and ataxia. You are unable to balance, vertigo and nystagmus. Okay, so risk factors are elderly patients, repeated courses of aminoglycosides and increased concentration. Next, nephrotoxicity. They get concentrated in the renal cortex and produce nephrotoxicity. It is highest with neomycin, nephrotoxicity. Okay. Next, neuromuscular blocking effect. They inhibit the release of acetylcholine from the motor nerve. So that is how they cause neuromuscular blocking effect. You can't give it in myasthenia gravis. Hypersensitivity reactions are rare, but if they are there, rashes, eosinophilia, urticaria, dermatitis, whatever. So streptomycin, T for TB. It is the first aminoglycoside discovered. It is used in TB. Gentamicin is gentle, so it is not used in TB. Rest all diseases like Proteus, Enterobacter, E. coli, P. aeruginosa, etc. Okay, gentle, so air. Okay. Next, neomycin. N for neo and for nephrotoxicity is more, so only topical skin infections you use it. Again, orally for you use neomycin sulfate. Okay. Next, amikacin is amicable. Okay, so that is why it has a broadest spectrum of activity. You use it in treatment of nosocomial infections. Now moving on to therapeutic uses of gentamicin and other aminoglycosides. So basically you use it in urinary tract infections, respiratory tract infections, meningococcus is effective, so meningitis. Okay, so it is gentle, right? So it can handle both peritoneum and also bone, rest all other than TB, right? So bone. So osteomyelitis and septicemia and peritonitis. Okay, burns also because it is gentle. So it is effective against P. aeruginosa. Also CVS, bacterial endocarditis, and TB also, streptomycin, kanamycin, amikacin are useful. Plague also you can use streptomycin or gentamicin. Moving on to broad spectrum antibiotics, tetracycline and chloramphenicol are broad spectrum antibiotics because they are effective against gram-positive, gram-negative, and bacilli and cocci. Okay, so tetracyclines, tetra 4 cyclic rings in their structure. So mechanism of action is they are actively taken up by susceptible bacteria. They bind irreversibly to the 30th ribosomal subunit and prevent charged tRNA, that is amino acyl tRNA, to bind to the mRNA ribosome complex. So what happens? It is preventing the addition of amino acids to the growing peptide chain because tRNAs, they carry amino acids which are added to the peptide chains, right? So this inhibits bacterial protein synthesis and is hence bacteriostatic. So resistance, it is due to decreased influx or increased reflux of the drug and inactivation of the drug by the enzymes. So what are the pharmacokinetics? It is orally given. Okay, it is metabolized in the liver. It is excreted in the in the form of urine. But doxycycline is excreted via feces, because just like dog, how it excretes via feces. So it is safer to use in renal insufficiency. Okay, so you can see this basic structure. It is very complex, right? So it forms complexes with calcium, magnesium, and irons. So it is a chelator, and when all these things are present in the food, they chelate with the drug and they decrease the absorption of the drug. So food decreases the absorption of tetracyclines. So what are the drugs? Oxytetracycline and tetracycline, all of them are oral. So absorption from the gut is incomplete, but doxycycline, the absorption from the gut is high. Okay, excreted through feces, absorption is also high, not affected, so it is safer. So half-life is, that is why more, it is absorbed more, it has a longer half-life, longer potency, so frequent dosing can be prevented. Half-life is only 6 to 12 hours, and here 24 hours. Okay, so what are the adverse effects? So it can chelate the calcium, right? So bones and teeth, it will make them more fragile, and it can cause brownish discoloration of teeth if it is used in infants. The next adverse effects: GI, nausea, vomiting, diarrhea. Liver, it is hepatotoxic and causes acute hepatic necrosis with fatty changes. Renal, it causes nephrogenic diabetes insipidus by blocking the action of antidiuretic hormone on the collecting duct. So it leads to SIADH. Skin, it can lead to photosensitivity and rashes or hypersensitivity. Okay, it can also cause superinfection, which is common with older tetracyclines because of alteration of the gut flora. And it can okay, this is what is written here. Therapeutic uses, what are they? So you can use it in chlamydial infections, rickettsial, Rocky Mountain fever, rickettsial pox, Q fever, scrub typhus, etc. Chlamydia, rickettsia, and mycoplasma. Okay, chlamydia, rickettsia, mycoplasma pneumonia, and malaria also doxycycline is used. Okay, DM, doxycycline, and malaria. Next, CBP. A, complete blood picture. So A for acne, C for cholera, B for brucellosis, and P for plague. You can use it on all these things. Okay, SIADH also. You can use other ones, but don't write it. Okay. Advantages of doxycycline over tetracycline: food does not reduce its absorption, so it can be used in renal insufficiency because it is excreted in the feces. It is more potent and has a longer duration of action and has less frequent dosing. Okay, so tigecycline, so tiger skin, right? So IV, so it can be used in serious skin infections. So tigers have a long half-life, so tigecycline has a long half-life. It can be given IV. Okay, and nausea, vomiting, diarrhea, and it also causes teeth to become brown. So chloramphenicol, it is a broad-spectrum antibiotic isolated from Streptomyces venezuelae. Even though it is a broad-spectrum antibiotic, it is restricted to only a few conditions for usage because of its dangerous side effect, which is bone marrow suppression. Okay, chloramphenicol. All the other drugs, so tetracyclines, amino glycosides, they bound to the 30th ribosomal subunit, but chloramphenicol binds to the 50th ribosomal subunit, prevents the formation of peptide bonds, and inhibits protein synthesis. So it is a bacteriostatic agent, but in high concentration it can be bactericidal. Okay, so it can also inhibit mitochondrial protein synthesis in mammalian cells by acting on 70S ribosomes. So resistance is by production of inactivating enzymes, and also decreased permeability of the microbial cell wall, so decreased influx of the drug and increased efflux of the drug. Okay, so pharmacokinetics, it is given orally, but it has a bitter taste, so it is masked by giving chloramphenicol palmitate suspension for pediatric use. And then it is activated by lipase in the intestines, and it is excreted via urine, mainly metabolized in the liver. Okay, just mainly metabolized in the liver by glucuronide conjugation. That is why it produces gray baby syndrome in kids, because they do not have glucuryl transferase enzyme. Next, adverse effects. So it is mainly because of inhibition of mammalian protein synthesis. So first, bone marrow suppression. Obviously, it is both dose-dependent suppression, which causes anemia, leukopenia, etc., and then dose-independent, which is more fatal. Okay, hypersensitivity reactions may include skin rashes, drug fever, as with other all antibiotics. GI effects are nausea and vomiting and diarrhea. It can also cause superinfection by disrupting the gut flora. And then gray baby syndrome, dose-related gray baby syndrome in neonates, because they have a deficiency of glucuronide transferase enzyme. So it causes refusal to suck, cyanosis, and irritability and circulatory collapse. Okay. So drug interactions, it interacts with warfarin, phenytoin, etc. by inhibiting hepatic cytochrome P450 isozymes. So what are the therapeutic uses? So remember, therapeutic uses, you can remember it as chloramphenicol. It needs to be tamed because it is not safe for babies. So tamer: typhoid, anaerobic infections, meningitis, eye and ear infections, and rickettsial infections. Macrolides, the prototypic example is erythromycin, so it is red, macro red. So erythromycin, it is effective against streptococcus mainly. Okay, so other examples you have them, but you don't need to remember them. It is active against most organisms, but not against Fragilis. Okay, macro, right? It is not small enough to be fragile, so not effective against Fragilis. Mechanism of action: it binds to the 50S ribosomal subunit, inhibits protein synthesis, but they are bacteriostatic. High concentrations they become bactericidal. Okay, pharmacokinetics: they are orally given, destroyed by gastric acid, so that is why you give enteric coated tablets. So because they are acid labile, it is metabolized in the liver. Okay, excreted in the bile. Why? Because the combinations are with stearate, etc., which are fat sites, so they're excreted in the bile. So preparations are erythromycin base system ledu, so estolate and stearate. Okay, adverse effects: so first, fat state, they're given enteric coated. Okay, acid labile, so GI side effects: nausea, vomiting, epigastric pain, etc., hypersensitivity reactions, obviously. So drug interactions, they are enzyme inhibitors. So erythromycin enteric coated, so GI manifestations. Erythromycin estolate preparations, enteral toxicity mainly. Enzyme inhibitor, so it inhibits enzymes metabolizing many drugs, so increases blood levels of warfarin, digoxin, etc., can precipitate fatal ventricular arrhythmias. So what are the drawbacks of erythromycin? It has a narrow spectrum, bioavailability is low, and poor patient compliance due to GI side effects. Okay, so to overcome the above drawbacks, semi-synthetic ones were invented. So clarithromycin. So mechanism of activity, again similar. Oral 50S subunit, it prevents the binding. It binds it and prevents its action, and achieves high concentration intracellularly. So it can be used in the treatment of macrolides. Okay, a Mycobacterium aeris complex, and leprosy, and Helicobacter pylori infections. Okay, so what are the comparisons? So source: natural erythromycin, clarithromycin, and azithromycin are semi-synthetic. Duration is short acting, and these are long acting. GI absorption is incomplete, and here it is complete. This is acid labile, rest are acid stable. Okay, so GI absorption, acid, duration of action, source. Next, antibacterial spectrum: it is narrow, and here it is expanded, and here you can use it in MAC. Okay, Helicobacter pylori, etc., here obviously in MAC, but again expanded, right? So azithrol, all, so salmonella, malaria. Okay, all. Next, dose enzyme inhibitions and dosage, you don't need to know them. Next, azithromycin, it can be given orally and intravenously. It is more effective against Haemophilus influenzae than others. Okay, so where is it used? So obviously in MAC. Okay, in MP also, Mycobacterium pneumonia, P for pneumonia, so you can use it in Legionnaires pneumonia as well. Okay, DPT, diphtheria, polio, diphtheria, pertussis, and tetanus, and chlamydial infections as well. So it can be used as an alternative drug in tetanus, and also streptococcal infections. Okay, strep throat, tonsillitis, pharyngitis, etc. Other uses: MAC infections in AIDS patients. Ketolides, so ketone bodies, they're toxic to the liver, so hepatotoxic, that is the serious adverse effect. So spectrum of activity and site of action is similar to that of azithromycin. Okay, it is used orally for community acquired pneumonia. Okay, pneumonia.